we'll just be sharing our screen, and we hope that this is going to be an interactive session. So in total, we have 20 cases, 10 of surgical pathology, 5 of hematology, and 5 of cytopathology.
Is the screen visible to all of you?
Yes, ma'am.
Yes, ma'am, it's visible.
Okay.
Okay, so moving on to the first case. Okay, so the first case, the history which was provided to you was 22-year-old male patient with history of hypertension, and we received a specimen of right red adrenal gland. So when you get this history, what comes to your mind? Dr. Nahida, would you like to say something regarding this? Am I audible?
Dr. Nahida, please unmute yourself and answer.
See, if you get this history, it's not a class, it's just an interactive session. So we are here to tell you from our little experience, whatever we have, how do we approach a case. So suppose you get this history. So before we move on to the slides or the specimen, what thing comes to your mind? Anybody else?
So Dr. Nahida, Hasti has answered pheochromocytoma.
Okay. So why you are saying straight away pheochromocytoma? That may be the diagnosis. But when you get the history, what other lesions can cause hypertension from adrenal? Okay, so let's come to the slide. So this was what was provided to you, this image. So Dr. Hasti, can you describe this? So what do you see over here? Anybody? Dr. Shweta, Dr. Srishti, anybody will like to volunteer? What you are seeing and what we are supposed to see? What do you think? What do you think this is?
One of the students can speak.
Cell balance pattern where there are
So it is a
nests of
circumscribed lesion, right? It is a
well
circumscribed lesion. And what you are seeing over here, you are seeing a tumor which is arranged in a Zell-Bollen-Klein architecture. Now, what do you mean by this term Zell-Bollen?
Ma'am, where the nests of these polygonal tumor cells are separated by fibrovascular septa.
Very good. Very good. So this is what you can see under this part. Now here you can appreciate the morphology of the cell. Can you just describe the morphology of this tumor? So these are polygonal cells and
they have abundant pale cytoplasm. And the centrally placed round nucleus with the salt, pepper, or stippled chromatin.
Okay, and kind of prominent nucleoli. So this was a pretty straightforward case, right? So because we are seeing more or less a uniform picture. What else you could have expected in this case? Or what you are expected to see in a suspected case of pheochromocytoma? Is it benign or malignant? Any student? I cannot see your, so you please volunteer for each.
Benign, ma'am.
It is benign, ma'am. 10% of the cases can be malignant, ma'am. 10% rule.
Okay, this is a kind of old concept. Now, all the tumors are considered to have some kind of malignant potential, right? So, but there are features which are associated with aggressive behavior. And now coming to the first thing which I'd asked, like when you get a history of hypertension and you have a mass in the adrenal. So how many parts of adrenal gland do we have? You have a cortex and you have a medulla, right? So can any cortical lesion present with hypertension?
Yes, ma'am.
Adrenal cortical hypercarcinoma, ma'am.
Carcinoma, okay. Hyperplasia and adenomas?
Hyperandrogenism.
Okay, very good. So this was kind of straightforward, and this is further just to highlight the architecture of these tumor, very organoid pattern, and you are seeing these septa, and the cells, they have kind of vesicular chromatin, and some of them have got prominent nucleoli. Now we should search for mitosis, atypical mitosis. In this case, we should search for any focus of lymphovascular invasion, then whether the capsule is involved or not, that we are expected to see in this case. Now, just for simplification, so this is an adrenal gland. Adrenal gland has got two parts, cortex and medulla. So they secrete different hormones. And in the cortex also, you have certain lesions, like you have hyperplasias, you have adenoma, and you have carcinomas. Though the difference between, in this case, the difference between pheochromocytoma and a cortical lesion was straightforward. Sometimes it may be there may be so much of ATP in a pheochromocytoma that it becomes difficult to distinguish, right? So medulla is the part which secretes catecholamines and peptides like epinephrine, norepinephrine, and somatostatin, which are responsible for the increased hypertension which you saw in this case. Can you name any other lesion which arises from the medulla? Forget about the age. Any common tumor which arises from adrenal medulla?
Carcinoid, ma'am? No.
Adrenal medulla. In children, any
Neuroblastoma.
Neuroblastoma, right? Neuroblastoma. So these are the tumors which you expect from adrenal cortex: cortical carcinoma, adenoma, sex cord stromal tumor, mesenchymal stromal tumor, and sometimes hematolymphoid tumors. And in adrenal medulla, pheochromocytoma, as you have rightly made the diagnosis of this case. And besides this, you can get composite pheochromocytoma and composite paraganglioma. So I'm glad that you all made this diagnosis. This was a straightforward case. Now moving on, okay. So it is a catecholamine producing tumor which arises from the chromaffin cell. So this is the site of origin. So when we were students, we used to remember this rule of 10 in pheochromocytoma, like 10% extraadrenal, 10% are bilateral, 10% are non-functional, and 10% are malignant. But now this is an old concept. 10% show metastasis, right? And 10% associated with inherited syndromes, and 10% can be seen in pediatric population. Now, adrenal, they arise from the chromaffin cells. So when you have to differentiate between a case, anybody, Dr. Pranjal, Dr. Nahida, Dr. Vaishnavi, if you would like to answer this question, suppose you encounter a case where you need to differentiate whether it is a cortical tumor or it is a pheochromocytoma. Is there any marker which can help you in that?
Madam, maybe we can give S100 for neural tumors and chromogranin A.
Chromogranin is very important. S100 will highlight the substanticular cells. When we saw this, just to move back. So substanticular cells are present in the septa. So S100 would highlight the substanticular cells. And the tumor cells would be positive for chromogranin and synaptophysin. And if you have to make a differentiation between adrenocortical carcinoma and pheochromocytoma, then chromogranin A is the marker which you should do, right? Chromogranin is very specific for pheochromocytoma. Now, current thinking, as I've mentioned, is that all pheochromocytomas have got some metastatic potential. Therefore, though you will find that several grading criteria have been given in your book, but now these all have been eliminated, and now we do a risk stratification according to the histological features which are present, like presence of any invasion, which may be vascular invasion, capsular invasion, or invasion into the periadrenal soft tissue. Large amount of cytological variation. Now, these cases are the ones which make you confuse them with adrenocortical carcinomas, like spindling of tumor cells, high cellular density, presence of monotony of cellular cells, or extreme pleomorphism. Then increased mitotic count, presence of atypical mitosis, lot of architectural variation, and necrosis. These are the features which point towards an aggressive behavior, right? Now, let's move on to the second question. This second case. This was a 37-year-old female patient with history of bone pain, multiple fractures, presented with a soft tissue mass in left hip. Now, Dr. Pranjal, can you just describe what you are seeing on this slide?
Madam, madam, it is specimen from bone. Showing
it's a soft tissue mass.
soft tissue mass from the bone, showing the stroma with mostly of spindle cells.
Very good.
And It's showing some lighter areas and darker areas in between.
Very good. So you are seeing very some lighter areas and some darker areas, right? Anything else you would like to elaborate upon? At this part, maybe you are seeing a bluish kind of tumor. You are seeing some giant cells kind of structures,
Yes,
which
yes, ma'am.
you are seeing some giant cells. Let's
Yes.
move on to the next power. Now here, what you are seeing, what are these things? What is this? What you are observing? This here.
This, ma'am,
Hmm.
this is a giant cell, ma'am. In the
Giant cell. This is a giant cell, right? This is a giant cell.
giant cell.
These are
And
giant
it's
cells.
showing the stromal, these fibroblastic cells, they are proliferating.
These are very good that you are very correct. There are some fibroblastic cells which are proliferating, but you are seeing many. What is this which you are seeing? Can you appreciate this bluish hue which is present?
Yeah, ma'am.
Okay.
Sorry, ma'am.
Okay, and Dr. Srishti, anything else? Dr. Srishti, would you like to add?
Plenty of giant cells that are scattered against background of
So,
stoma.
what do you
And
think
the
this
next
lesion can be?
see cartilage also. The next
Yeah, okay.
was
You are seeing some.
okay.
This, I think you are referring to this. This looks like cartilage. And what are these structures? These are?
Two sides.
Nee, this looks like cartilage, and these are blood vessels, right? These are blood vessels.
Yes,
And
ma'am.
these
And
are,
this is,
then are these the
but
cholesterol
still,
plaques? Are these the cholesterol plaques?
no, these are not cholesterol clefts. Initially, when we got this case, we thought that the technician has not cut this properly. So maybe these are knife serrations which you are seeing, because there is a lot of calcification in this tumor. What this blue thing which you are seeing is nothing but calcification. This is a calcified matrix and some cartilage-like structures you are seeing over here. Now, this is the high power view of these spindle cells. Now, can you make a diagnosis? Did you reach at a diagnosis or any differential diagnosis in this case? You said that it looks like a spindle cell tumor to you. You said this is a spindle cell tumor which is showing you some giant cells, and you could appreciate some cartilage-like structure. I gave you this extra point that there is lot calcification, this dirty looking calcification which you are seeing in these slides. This is again dirty looking calcification. So these tumor cells are embedded in a basophilic matrix which has undergone some calcification, and you are seeing some cartilage-like structures. And we also had some blood vessels which are like here, and in some areas which I have slides which I have not given you, that there were some osteoid-like areas also in this tumor, and some entrapment of fat also. Now, if you look at these spindle cells, do you think this spindle cell population is benign or malignant? Dr. Nahida, Pranjal, Srishti, Shweta, anybody can answer this.
It looks like benign, ma'am.
It looks like very good. So because there aren't any mitotic figures, there isn't much necrosis. Now, I'll give you one more history which I had not provided you earlier, that serum phosphorus in this patient was found to be very low. So can you now think of some entity?
Brown tumor.
Brown tumor of hyperparathyroidism
Sarcoma,
typically occurs in jawbones, right?
Yeah. Can it be fibrous dysplasia, ma'am?
Fibrous dysplasia, again, what do you see in fibrous dysplasia? You will see Chinese letter pattern of the bone cavity. So it is not fibrous dysplasia. And this is a very rare case, and actually I had this in my tray, so I just clicked a picture for you all. Before I go, I'll just tell you what again revise, because this you will see maybe 2-3 cases in your lifetime. So this is a tumor composed of spindle cells with some entrapment of fat, and the cells are spindle shaped. They have embedded in a basophilic kind of matrix which has undergone a dirty calcification. The name for this dirty calcification is grungy calcification, and there are areas which resemble a primitive cartilage. The blood vessels may or may not be prominent in this case. In this case, they were prominent. Sometimes they become hemangioparasitomatous also, and sometimes they may be slit-like also. And as you can see that there are giant cells, and there aren't any mitosis or necrosis. So you're not thinking of a sarcoma in this case. And giant cell tumor also we can exclude because giant cells are scattered. They are not evenly distributed, right? So you have excluded a differential of giant cell tumor of soft tissue, a soft tissue sarcoma, and I have provided you an extra history that serum phosphorus is low. So this entity is known as phosphatiuric mesenchymal tumor. So the key histological features which we have seen are there is proliferation of blunt spindle to stellate cells. In our case, there was some more proliferation. The matrix was quite blue. So it has got a basophilic matrix which undergoes calcification. And the term which is used for this kind of calcification is grungy or dirty calcification. And there are scattered areas. They may be scattered areas with osteoid morphology or primitive cartilage. So what we saw was a kind of primitive cartilaginous structure, but it is not a chondrosarcoma, right? Because chondrosarcoma, you expect more atypia. And you will see hyaline cartilage and you will see more atypia in chondrosarcoma. There was presence of osteoclastic giant cells. Some amount of tumor vasculature we could see, but it was not like hemangioparasitomatous kind of areas. And there was infiltration of fat. Sometimes, though it is a benign tumor, sometimes it may turn into malignancy also. So malignant PMT is associated with increased mitosis, necrosis, and higher nuclear grade. So it is a very rare tumor which involves soft tissue or bone. Now, I had given you a history of multiple bone fractures. Now, because there is tumor-induced osteomalacia because of production of fibroblast growth factor 23, which is a phosphatiuric hormone which acts on renal proximal tubular epithelial cells, and there's low serum phosphorus, low vitamin D3, and on IHC, these cells are positive for SAT-B2, CD56, and fibroblast growth factor. And differential diagnosis, as we have discussed, is from giant cell tumor of bone and soft tissue, solitary fibrous tumor, and mesenchymal chondrosarcoma. I hope you all have understood the morphology of this case because it is a very rare case. And maybe I've seen only 1 or 2 cases in my lifetime. So it is a rare case. And when we first got this case, we thought that the technician has not cut it properly. Then we inquired about the history and we got this history that the phosphorus levels were low. Can we proceed to the next case? Any confusion or can we proceed? Okay. So this was case number 3. So this was a 26-year-old male patient with right-sided vision loss and headache for 10 months. And it has the lesion had the epicenter in sphenoid sinus and sellar region. And it was extending, towards the ethmoid bone also. And this is what we got. Can you explain this case? Anybody? Nahida, Srishti, Hasti, anybody? Anybody would like to volunteer what you are seeing in this case? Dr. Srishti, Dr. Vaishnavi, Dr. Shweta?
Mom is a soft tissue tumor showing
Very
some
good.
spindle cell morphology.
Very good.
Showing
Stellate
apparent
cells. Spindle to stellate cells, soft tissue tumor. Very good.
showing in between a few spaces, clear spaces.
Okay. So it is a myxoid tumor and you are seeing these stellate cells. And there are some. This is a
Giant cells.
giant
Giant
cells.
cell.
And at some places there was some fibroblastic proliferation as well. And you can see that these are stellate cells. And the radiologist told us that the matrix is quite calcified. And because base of skull was involved, their first diagnosis was that of a chordoma. So do you think it is a chordoma?
Mom, 5 cells should be
They are
seen.
not seen. Okay.
Do not see them.
Okay, very good. So what it can be? So you are seeing some stellate cells, you are seeing some myxoid and fibrous matrix, and you are seeing few giant cells. So what do you think the lesion can be?
Some neuronal tumor, ma'am.
Neuronal tumor. Okay. So what kind of morphology of spindle cells do you expect in a neuronal tumor? Myxoid areas would be there, but these are more stellate cells, right? And in neuronal tumors, you will generally not see giant cells. And the history of cartilaginous matrix, which the radiologist provided, goes against a neuronal tumor. Anything else which comes in the differential of chordoma is one. Their differential was chordoma versus chondrosarcoma.
Could be, ma'am, cyanonasal myxoma.
It is a you are close. It is a myxoid lesion. So first we gave it as a myxoid mesenchymal neoplasm, and then we did some markers, and this came out to be, these spindle cells, they came out to be S100 positive. Now, so we favored a diagnosis of, so these were the cells, right? These were the cells. So they are very stellate and spindle shaped cells without any atypia. So we gave a diagnosis of chondromyxoid fibroma. Based upon that, it is a rare benign bone tumor. Now, it is less than 1% of all primary bone tumors, and it typically arises in the long bones. Now, craniofacial involvement is uncommon, and craniofacial chondromyxoid fibromas are further classified as calvarial CMFs and sinonasal CMF. Calvarial are limited to frontal and occipital bones, where sinonasal ones, they involve the nasal cavity, orbit, zygoma, and have cellar and paracellar involvement as well, and higher chances of recurrence. Though chondromyxoid fibromas are considered as benign, but in craniofacial chondromyxoid fibromas, they can be very, they can behave very aggressively in a local manner. So that is why the patient presented with such symptoms. So radiological features of CMF, it resembles other cartilaginous tumors like chondrosarcoma and chordoma. So this is what, so radiologists thought it is a cartilaginous tumor. So we got this myxoid neoplasm, and the radiologists were thinking that I was in the direction of malignancy because of the widespread symptoms of the patient. But we had extended positivity, brachyury was negative, and it was not looking like chordoma in any sense. EMA was also negative. So we favored a diagnosis of chondromyxoid fibroma in this case. Okay. Now, these are the further differences between these three entities. Now, chondromyxoid fibroma, they have lobules of spindle-shaped stellate cells, abundant myxoid or chondroid matrix, and there's at periphery you may find some cellular regions, and variable number of multinucleated giant cells can be seen. So in this case, we saw some giant cells, and on IHC they are positive for S100 in SMA. Now, differentiation was with chondrosarcoma was simpler for pathologists, but radiologists and the clinician, they were thinking, because it was invading into the adjacent bone, so they were thinking of chondrosarcoma, but we did not find infiltrative lobules of cartilage or nuclear atypia. And chordoma, again, as you all mentioned, that there wasn't any presence of any ficelliferous cells, so chordoma could be excluded. Now, moving on to the next case. Now, this is an interesting case. 28-year-old male patient with dorsal agenesis of pancreas who underwent Whipple's resection. Can anybody tell me what are you seeing in this case?
And we can
What are
see
these?
normal pancreatic acini along
Very
with an
good.
underlying neoplasm, ma'am.
Okay. So these are the pancreatic acini. These are the normal ducts, and this is the tumor part, right?
Yes, ma'am.
Okay. Can you describe the tumor?
Ma'am, the tumor cells are arranged in trabecular pattern and sheets with round to oval. The cells are round to oval in shape with eosinophilic cytoplasm and salt and pepper chromatin. The nuclei has salt and pepper chromatin.
Very good.
So more of a neuroendocrine origin, ma'am.
Okay, very good. So I would say that these tumors are arranged in a very organoid pattern. So what is this structure which you are seeing? What is this? This is the tumor, right? These are the organoid pattern of tumor, nest of tumor cells, and you have described the morphology correctly. But what is this structure which I'm seeing over here? Any guesses?
Could be any nerve.
Very good. It looks like a nerve. Very good. So is it a part of the tumor, or the tumor is around a nerve?
Tumor is around this nerve, I think.
Okay, we also thought the same initially. Okay, so I'll come back to that. So this you have described that these are the nests of tumor cells, and they've got a salt and pepper chromatin. These are the septa which are surrounding, and tumor cells are very monotonous, right? There isn't any mitotic activity, no necrosis. So it looks like a neuroendocrine tumor to us. Now I'll provide you some additional images. What are these structures which you are seeing? What are these things? What cell is this? Anyone?
It looks like a
Looks like a
ganglion.
very good. It looks like a ganglion cell. So we saw a neuroendocrine tumor. Neuroendocrine, we all agree upon that. We saw some nerve-like structure, and there were huge nerve-like structures present in this case, and we saw some ganglion cells. Can you now, would you like to revise your diagnosis? Can you think of some entity which has got all these three components? Sorry.
It's a ganglioneuroma.
But if you say it is a ganglioneuroma, what about this tumor which you are seeing?
Yes.
What about this? What is this? So can you make a fusion of these things? So you have a tumor which is showing you presence of some nerves, some ganglion cells, some neural structures, some ganglion cells, and you are seeing a neuroendocrine tumor. So, and then, okay, another thing I like to show you, what organ is this? This looks like, this is from Whipple's only. We took a section from duodenum. These are
No.
Brenner's gland. Again, you are seeing a tumor nodule in the submucosa. So you have a tumor with epicenter in pancreas, which is extending till duodenum, and you have observed three components. Can anyone, final year PG, any final year PG amongst us? So this is a composite gangliocytoma neuroma and neuroendocrine tumor, which is now known as COGNET. Initially, the earlier term for this tumor was gangliocytic paraganglioma when I was a postgraduate student like you all. So we used to learn, memorize these entities. Sometimes you get lesions like this if some examiner who brings us a slide like this, and this location is from ampulla or duodenum. So this is one of the possible entities. The unique thing about this case was that though we found this tumor both in the pancreas as well as the duodenum, the epicenter was in the pancreas. This tumor was also involving the common bile duct, and the patient had dorsal agenesis of pancreas, so it became a unique case. And otherwise, this tumor is seen mainly in the duodenum. So first we thought that it is a neuroendocrine tumor, and it is probably having some perineural invasion. But then we saw some ganglion cells, and we then came to this conclusion that nerves are a part of this tumor. So COGNET is a rare triphasic tumor which has got this epithelial neuroendocrine cells, spindle Schwann cells, and presence of ganglion cells. So these are the three components of COGNET. The earlier name for this tumor was gangliocytic paraganglioma, but now it is believed that this tumor is more related to a neuroendocrine tumor. It is more related to neuroendocrine this thing rather than a paraganglioma. Paraganglioma, what is the difference between a neuroendocrine tumor and a paraganglioma? Paraganglioma is a non-epithelial tumor, whereas neuroendocrine tumor are epithelial tumors. So CK would be positive in a neuroendocrine tumor, CK will not be positive in paraganglioma. So the earlier term for this tumor was gangliocytic paraganglioma. So these are the components: neuroendocrine tumor, gangliocytic component, and a neuromatous component. This predominantly involves the duodenum and rarely the pancreas. So you will see a nest of epithelioid cells, ganglion cells, and spindle Schwann-like cells. And the different areas will show positivity for different markers. Like NET component would be positive for chromogranin and xanthophysin and cytokeratin, whereas neural component would be positive for S100 and non-specific enolase, and ganglion cell component would be positive for calcitonin. So you will do grading for the NET component. Usually it is benign, indolent in nature, and as I mentioned that it presents as a submucosal polypoid lesion in the duodenum. The unique thing about our case was that the epicenter was in pancreas, and the prognosis is excellent. Neuroendocrine tumor, on the other hand, it is a monophasic epithelial tumor and shows only neuroendocrine differentiation. Right. So this was an interesting case which we recently encountered. Now moving to the last case, which is a 52-year-old female patient with complaints of swelling over left angle of mandible. Last case from my side. Dr. Garima would be presenting more cases. This was a 52-year-old female patient with complaints of swelling over left angle of mandible since 6 months, and we received a left superficial lobe of parotid gland. So, would you like to explain this slide? Anyone? Anyone would like to explain this slide? Dr. Vaishnavi? Dr. Pranjal?
Ma'am,
Ma'am,
here,
is it
Please go ahead.
ma'am, here we can see normal parotid acini with
Okay.
underneath there's a capsule, and underneath that there is a neoplasm.
Very good.
Ma'am,
So, in this part, can you describe the neoplasm?
ma'am, the neoplastic cells are arranged in cords or sheets, ma'am. Not very
Sheets.
much.
They are
Sheets.
arranged in sheets.
Sheets,
Okay.
and
In between, you have some spaces. In between, you have some spaces, right? Punctuated by some spaces and some blood vessels. And you're also seeing some lymphoid infiltrate and it's infiltrating the capsule where there is some tumor associated
invasions
lymphoid
also.
proliferation. So coming to a higher power for you, huh? Now you can describe?
Yes, ma'am. The individual cells are again round to ovoid, ma'am, with mild eosinophilic cytoplasm.
And anything about the architecture? See, it is solid. Then there's some, some structures like papillary structures which are protruding inside a lumen, which you are seeing over here.
Yes, ma'am.
Right. And these are sheets of cells, and in between you have some cystic spaces, some slit-like spaces, and then some papillary architecture is there, which I think you can appreciate over here. Can you describe the morphology of the tumor cells? How do they look like? Here, some tubules are also there. So this is a tumor which is showing you a variety of architectural patterns. Some glandular structures are there, some papillary structures are there, some solid sheets are there. And can you describe the morphology of these tumor cells? What is the shape of these tumor cells? Kind of polygonal in shape. And they've got centrally located nuclei, inconspicuous nucleoli, and an abundant amount of granular cytoplasm. So what do you think the tumor is?
acinic cell carcinoma?
Any other differential? Why did you say acinic?
Because myopithelial, it may be myopithelial carcinoma also, ma'am.
Okay, so
Is
what
a
are the
glandular
features?
pattern showing monomorphic these nuclear structures means it is monomorphic, and glandular structure is that's a acini.
Big glandular structures are there, plus a lot of cystic spaces and papillary structures are also there. And these cells which you are seeing, do they resemble, okay, what kind of cells can you see in an acinic cell carcinoma? You can see the acinic cell per se. Any other cell which you can see? You can see these cells have got
These are mitotic, I think, somewhere.
occasional mitosis were there in this. But what I'm trying to tell you is that looking at the cytoplasm, the usual acinic cell, the normal acinic cell, that looks quite blue. Here the cytoplasm is a bit eosinophilic. So even in acinic cell carcinoma, there can be a number of cell types which give rise to acinic cell carcinoma. It can be the acinic cell, it can be the intercalated duct cell, it can be the non-specific glandular cell also. So when you see a variety of architectural pattern, see, you have sheets, you have papillae, you have glandular pattern, and the cells, the shape is polygonal. So here it is looking more of eosinophilic. At other places, you can see some mucin also. So the diagnosis was acinic cell carcinoma. Which marker do you do for acinic cell carcinoma? Specific marker for acinic cell carcinoma is DOG1, right? So it comprises 6 to 8% of all salivary gland tumor. It is seen in most common in parotid gland. So whenever you see a salivary gland tumor, you should always try to see whether it is involving a major salivary gland or a minor salivary gland, because the list of tumors is different for each type of salivary gland. Now it presents as a encapsulated round mass. The pattern of growth can be solid, it can be microcystic, it can be papillary or follicular. They have got abundant cytoplasm filled with basophilic zymogen granules. Now, in our case, the cell type which we were seeing were intercalated duct cell type and non-specific glandular. You can otherwise get typical normal ethnic cell carcinoma, normal ethnic cell, intercalated duct cell, clear cell, vacuolated cells, and non-specific glandular cells. These granules which are present in the cytoplasm or ethnic cell, they show past D positivity. So they arise from the terminal ductular acini unit of the salivary gland, and these are the different cell types from which it can arise. The specific marker for IC marker for ethnic cell carcinoma is DOG1 and SOX10. In special stains, it is past D positive. The closest differential is from secretory carcinoma, which is S100 positive, and it shows this ETB6 and NTRK3 fusion. Salivary duct carcinoma will show you more amount of necrosis. It is more higher grade tumor. Sometimes when oncocytic change is there in ethnic cell carcinoma, you can also confuse it with oncocytic carcinoma, but it will be negative for DOC1. And sometimes when mucin is abundant, mucoepidermoid carcinoma also comes in differential. But in this case, the diagnosis was simple, and we had a confusion between ethnic and secretory, and we did DOG1, and DOG1 was positive in this case. So the final diagnosis was ethnic cell carcinoma. Now we'll move to case number 6.
Okay, I hope you all do not have any doubts in the previous cases, because if you have doubts, then we can take those doubts. Or shall we go ahead? Okay, so case number 6 was a 51-year-old female with retraction and ulceration of the right nipple. Okay, so have you all gone through the slides? So can you tell me where is the lesion located? You can see a epidermis here, right? And then beneath that is the dermis. So where do you think is the pathology?
Miss ma'am.
Shrishti? Yeah, Vaishnavi. Yes, please.
It is
Where
located
is the...
in the epidermis, ma'am.
Okay. And what other changes do you see at this power, which you can appreciate in the epidermis, other than the pathology? We'll come to the pathology in the epidermis. So what other changes can you see?
There's hyperkeratosis.
Yes. There is hyperkeratosis. And there is some amount of increase in the thickness. So there is acanthosis. Right. So we'll just go to the, can any one of you describe the pathology here on higher power? Do we all agree that there is some amount of ATPI in these cells here, right? So can you describe these cells? How will you describe these cells? So there is hyperkeratosis, there is acanthosis, and then the pathology is limited to the epidermis here. What we can see is it is limited to the epidermis. Now, we see that there are there is presence of these large cells. So can you describe these large cells?
Cells.
They are, sorry.
Vacuolated.
And
okay, so they have pale
nucleus
eosinophilic or vacuolated cytoplasm. Okay, then. Yes, Dr. Shrishti. The nucleus. Anything about the nucleus? The nucleus is also large, round, and you can see here it is showing a prominent nucleolus. Now, why is this pale vacuolation there in these cells? Because of presence of glycogen. Okay. And in the dermis, you see that these cells are limited to the basement membrane and they are not in the dermis. The dermis is showing some amount of chronic inflammation. So at this point, would you like to come up with some differentials? And if you see here, you can also see some amount of melanin pigment in few of these cells. So what is your differential diagnosis here? It's a very straightforward case.
Paget's disease, ma'am.
Okay, that is one, Paget's disease. Anything else you would like to differentiate it from?
Maybe from...
Though the history and the morphology both point towards Paget's, but just for the sake of discussion, any other differentials?
In invasive breast carcinoma, so that's the tumor cells.
Breast carcinoma, yes, there may be an underlying DCIS or an underlying invasive malignancy, but here at this power and in this slide, we did not see any invasive carcinoma.
Or maybe some, ma'am, with the normal Toker cells that may
Okay,
normally
very
present.
good. So this can be normal Toker cell hyperplasia and Toker cell dyskeratosis. Okay. So we'll come to that. How do we differentiate? But let's just discuss all the other differentials. So one is Toker cell hyperplasia, Paget's disease. Anything else? If I say that this is melanin pigment here deposited in some of these cells, so what will you think of?
Melanoma.
Yes, a melanoma in a radial growth phase, right? A melanoma in situ and also a squamous cell carcinoma in situ, so which is known as Bowen's disease. So that is again another differential. So though IHC is not required for this diagnosis, and we without the IHC gave it as Paget's disease of the nipple, but CK7, as you can see here, is highlighting these Paget cells. Okay, so CK7 is positive, and also HER2/neu is showing membranous positivity. We also did a HMB45 and it was negative, so ruling out a melanoma in situ or a radial growth phase. Now these Paget's, so the diagnosis here is Paget's disease of the nipple, and it is most commonly seen in postmenopausal women in the 6th decade. It's usually a unilateral lesion with nipple pain or irritation, and nipple erythema, discharge or ulceration may be present, and up to 50% of these patients have a palpable hard underlying mass, which may be DCIS and or a invasive malignancy. So what you saw on microscopy was intraepidermal large cells with round large nuclei, prominent nucleoli, and abundant pale vacuolated cytoplasm. So this pale vacuolation is because of glycogen. So these will be PAS positive, and the mitotic activity, pleomorphism, that can be variable. These cells can be present as present in clusters or singly at the dermoepidermal junction, and sometimes they phagocytose melanin, as in this case, which may mimic melanocytes, and that is why one of the differential is a melanoma in situ. The epidermis, as you all correctly pointed out, showed the acanthosis and hyperkeratosis, and dermis showed chronic inflammation. So underlying carcinoma is, if it is present, is most commonly high-grade invasive ductal carcinoma of no special type in 53 to 64% of cases, or a DCIS in 24% to 43% of cases. Now, where do these Paget cells come from? So there are two different theories about it. One is the epidermotropic theory, where it is thought that the DCIS, the cells from the DCIS ducts, they migrate to the surface of the skin and in the epidermis. The other theory is the intraepidermal transformation theory, where the Toker cells, which are usually present in the basal layer of the skin, they transform into Paget cells. So that is why Toker cell hyperplasia is one of the differential diagnoses. So melanoma with radial growth phase, Bowen's disease, that is carcinoma in situ of skin, Toker cell and pagetoid dyskeratosis or Toker cell hyperplasia, they come under the differential diagnosis. Now, how do you differentiate these Toker cells from Paget's disease of the nipple? So they will also show enlarged nuclei, small nucleoli, but the pleomorphism will be minimal. These Toker cells also are negative for a mucin stain, whereas Paget's disease, they can show positive mucin stains. Okay, so IHC CK7 is positive in both. So the differentiating feature is the presence of GCDFP IHC. So GCDFP 15 is negative in Toker cells, whereas the Paget's disease, it will be positive. So is this clear? Any doubts here in this? Any doubts anyone has? Shall we move on to the next case? So these cells are, the Paget cells have vacuolated cytoplasm because of mucin, and it is positive for stains like mucicarmine. Okay. So we move on to the next case. It is a 43-year-old male with bilateral undescended testis and Mullerian remnants. So this was the first picture provided to you? Can anyone describe? What do you see here? Dr. Nahida, Dr. Hasti?
Ma'am, there is a seminiferous tubule.
Okay, here. Yes. That was for you to identify the organ.
Organism.
Okay. Then what about the tumor? Let's go to a higher power.
Ma'am, the
Anybody?
tumor
Yeah.
cells are pretty much uniform looking
Okay.
with clear cytoplasm, ma'am.
Okay.
And
So
the
what is this clearing of the cytoplasm, do you think, because of?
glycogen content.
In Paget's disease, it was because of mucin. Here it is because of
Glycogen.
glycogen. Okay. Then?
And we can see centrally placed nucleus, ma'am. Prominent nucleoli is also it can be appreciated in most of the cells.
Okay. Any other feature which is striking? What is the arrangement of these cells? You've described the cells nicely, but what is the arrangement of these cells?
They're nested.
Lobules.
Yeah, lobules, sheaths, which are separated by
Fibrous septa, ma'am.
fibrous septae. And anything in this fibrous septae do you see?
There is lymphocytic infiltration, ma'am.
Lymphocytic infiltrate. See, nested pattern would be what you saw in case of pheochromocytoma, that Zellbalan or organoid pattern. Okay, here it is more of lobules or sheets of tumor cells which are separated by these fibrous septae, and these fibrous septae have lymphocytic infiltrate. So here you can see on a higher power, these are the cells. So they have clear cytoplasm, a round to oval nucleus with a prominent nucleus. Okay. So any diagnosis? Broad diagnosis?
Seminoma testis.
Okay, seminoma. Any differential you would like to consider here? These are the pictures showing the same. So yes, the diagnosis was seminoma, and it is the most common histological type of germ cell tumor. The peak incidence is in the 4th decade, and it contains isochromosome 12p and expresses OCT3/4 and NANOG transcription factors, and it may have c-KIT activating mutations. So now, why this case was included? So what is the counterpart of seminoma in females?
It is germinoma.
And if I say that the patient had a mediastinal mass or a CNS tumor with the similar morphology, what do you call it there? Similar morphology. Seminoma, dysgerminoma, and germinoma. Okay, so there it is called germinoma. Okay, so microscopy, as we've already seen, sheaths or lobules of tumor cells separated by fibrous septae with presence of lymphocyte cells are typically pale to eosinophilic. Cell membranes are well defined with distinct cell boundaries, and the nuclei are polygonal, may have flat edge, giving it a squared off box-like appearance, one or more prominent central nucleoli. Also, what you can see is granulomas in 50% of the cases. And when syncytial trophoblasts are seen, which is seen in 20% of the tumors, there will be an increase in the beta HCG levels. But remember that the beta HCG levels will never reach up to the level of choriocarcinoma. Okay, so there might be a mild increase in beta HCG. Then what else you have to look for in a seminoma is the intratubular seminoma in the adjacent. Germ cell intratubular neoplasia. Okay, in situ. So now this was given to you for the how do you approach any germ cell tumor in the testis. So germ cell tumors can be, now the new classification says that they're the ones which can be associated with germ cell neoplasia in situ or the ones which are not associated with germ cell neoplasia in situ. So under the germ cell tumors which are associated with GCNIS, we have seminomatous tumors and non-seminomatous tumors. So seminomatous tumors is seminoma, and non-seminomatous can be embryonal carcinoma, which can further be divided into choriocarcinoma, teratoma, or yolk sac tumor. And then the tumors which are not associated with germ cell neoplasia in situ include spermatocytic tumor, which was earlier a part of seminoma, and was called as spermatocytic seminoma, but now it has been called as spermatocytic tumor, and then prepubertal teratoma and prepubertal yolk sac tumor. So this is important to know that in prepubertal teratoma, in prepubertal yolk sac tumors, there is no association with GCNIS, and also in spermatocytic tumor, there is no association with GCNIS. So non-seminoma, so this is how the pluripotent germ cells, they mature into gonocytes, which again mature into spermatogonia. So from pluripotent germ cells, there is formation of a germ cell neoplasia in situ, and when there is a gain of chromosome 12p, it can go in for a seminomatous tumor, or with this GCNIS can directly convert into an embryonal carcinoma, and after hypermethylation or differentially expressed genes, it can convert into choriocarcinoma, yolk sac tumor, or teratoma. Whereas you can see that the other tumors which are not associated with GCNIS, there they follow a very different course. Okay, in adulthood, it can result in spermatocytic seminomas, and in young children, it can lead to teratomas or yolk sac tumors. So also of importance here is that the prepubertal teratomas and the prepubertal yolk sac tumors are pure tumors, whereas the ones which are associated with GCNIS, they are usually mixed germ cell tumors. They are not pure tumors. So in an adult where you see a tumor associated with GCNIS in adults which are not prepubertal, then you will usually see a mixed germ cell tumor pattern. Unlike in prepubertal young children where it is not associated with GCNIS, where it is a pure tumor, pure teratoma or pure yolk sac tumor. Okay. Now, what is the role of immunohistochemistry in differentiating these tumors? So germ cell tumors, they can be divided into OCT4-34 positive and OCT4-34 negative. Also, you can use SAL4 or PLAP. Then if the tumor is CD117 positive, CD30 negative, it is seminoma. CD30 positive, CD117 negative, embryonal cell carcinoma. So if it is CD30 positive, embryonal cell carcinoma, CD117 positive, seminoma. If the tumor is positive for Glypican-3 AFP, then it is yolk sac tumor. Then spermatocytic seminomas will be negative for all these, and choriocarcinomas will be positive for HCG. Okay, other markers may or may not be present. Also, what is the role of the tumor markers to differentiate between the germ cell tumors? So seminoma may show beta HCG, but as I told you, that beta HCG will only be raised to a certain level, but not as high as in cases of choriocarcinoma. Yolk sac tumors, you will see an increase in the AFP levels. Embryonal carcinoma, if it is mixed germ cells, so AFP and beta HCG. Teratoma, there is no marker, and teratocarcinomas can show an increase in AFP and beta HCG. So seminomas can again have an increase in the LDH levels. So based on the serum tumor markers, we can stage these tumors as S0, 1, 2, and 3. So based on LDH, HCG levels, and AFP levels. So if everything is normal, then it is S0 stage. If the LDH levels are less than 1.5 times the normal, and the HCG is less than 5,000 and the AFP is less than 1,000, then it is stage 1. Stage 2, when it is the LDH levels are 1.5 to 10 times that of normal, or the beta HCG levels are 5,000 to 50,000, or the AFP levels are between 1,000 to 10,000, then it is stage 2. And stage 3, when the LDH levels are more than 10 times the normal, or HCG levels are more than 50,000, or the AFP levels are more than 10,000. So the tumor markers are also play a very important role in prognostication and staging of the germ cell tumors. So why this case was more interesting was this was the gross of the undescended testis. But what else was present was, so if you can just stretch your imagination, you can see this was the endometrial cavity here. Okay. And this was the cervix. Also, there was fallopian tube. So there were Mullerian remnants in this case, and both the testes were undescended. So till the time I'm presenting this case, we did not have the karyotype, but they were expecting it to be 46XY. So they were just waiting for the karyotype of this patient. So this patient had a gonadal dysgenesis and Mullerian remnants from, so this was the uterus, which they sent it as a uterus-like structure. And this was the seminoma. So you can see the lobular pattern, gray-white, uniform appearance here. Okay. Any doubts till here? Anyone? Is this clear? Okay. So case 8, 65-year-old female with anterior